Everyone looks comfortable to me, so I think we should go ahead and get started. Welcome, folks. You are at CareOregon Pharmacy's Meds Ed presentation today, Advanced Illness Care and Empowering Patients Within Those Environments. Just real quickly on this slide here, you will see a breakdown of our timing agenda for this morning. You do have a couple of breaks scheduled here, depending on how timing goes. Hopefully those will both be 15-minute breaks, but you never know. Sometimes a segment can run a little bit long, and the Q&A gets a little bit more extreme and exciting. So we'll sort of view this agenda as a rough set of guidelines. Without further ado, I'd like to go and introduce our first presenter to you today, Senior Medical Director for Advanced Illness for CareOregon and Housecall Providers, Dr. Will Kennedy. When Will is not taking care of our fragile population in great need, he's also the relief bass player for Metallica, is what I've just recently learned this morning. So a lot of times he enters the room, there'll be a big cloud of smoke and lasers and lights, but hopefully we're keeping that to a minimum today. But he is still a presence to be reckoned with. Please join me in welcoming Dr. Will Kennedy.
Is that Ian? Can you hear me okay? Okay. So the point of that was we were joking when we were setting up this conference that would be my intro. Or raising from the stage, how they come out, right? So not very palliative care-ish. So just for context, for those of you who don't know me, I have been in Oregon for 10 years, and I was the medical director for a hospice and palliative care service here in town, doing full-time clinical medicine, and then had done 10 years of palliative care and hospice in Ohio, as we'll talk about in San Francisco and Ohio before then. And then I've been at CareOregon since 2013. So that's just a little bit of the background. I don't have any conflicts of interest to disclose. What are our learning goals today? We'll talk about how do we serve our community's most vulnerable members living with advanced illness, and what partnerships do we need to provide this care? And then finally, how do we develop resilience to moral distress and burnout? And so really it's a two-part presentation or a two-part message, which is one, talking about the patients we serve, and then talking about ourselves. Okay? So this picture I took a little over 20 years ago. I was walking down the street in Boston as a fourth-year medical student, and for a brief period of time in my life, I was into photography and happened to have a camera with me with black and white film in it. And I just looked over and saw him, and it stopped me in my tracks. As you can see, he's sitting there, his head is in his hands, there's no sign asking for food or money, and even fast forwarding 20 years where, having done 20 years of palliative care and seeing a lot of despair, to this day I still have not seen an image or a moment that filled me with more despair than what I saw then. And so it was so profound, I took a photo because he was looking down to, I guess you would say, to memorialize it. And it's been framed in my apartment, in my house, and then for many years now in our palliative care office as sort of a North Star. And how I felt at that moment was the following. How does this story end, right? And looking at him, I felt an incredible empathy to want to help him, but I also felt entirely paralyzed. I had no idea what to do. So it stayed with me. It wasn't that I was a fourth-year medical student about to start residency. It wasn't that there was something that I was going to learn in the coming months or years even that would have made a difference, but certainly it stayed in my heart that way. So about 10 years later, when I'd finished my residency, practiced as a hospitalist, done a palliative care fellowship, and done different types of hospice and palliative medicine clinical practice, I saw this quote by Bill Gates, and this was at a Harvard commencement speech that he gave, and he was talking about his personal transition that he made from being the CEO of Microsoft to working full-time for his foundation to address global health inequity. So I'll read it here. All of us here in this yard at one time or another have seen human tragedies that broke our hearts, and yet we did nothing. Not because we didn't care, but because we didn't know what to do. If we had known how to help, we would have acted. The barrier to change is not too little caring, it is too much complexity. And that was the first time for me that I think I started thinking about that encounter in a different way, rather than just a moment of paralysis, but instead that it was something more complex that I did not know how to deal with, but somehow that was more tangible going forward. And that stayed with me as a second, you might say, second clue or second lesson in this process. And about this time, I took a job moving from Ohio to San Francisco at Laguna Honda Hospital. And if you know San Francisco, you know Laguna Honda. If you've worked in healthcare, if you don't, Laguna Honda is what was considered the first alms hospital, the charity hospital in the city. It was built in the 1800s. It sits upon an amazing mountain in this incredibly wealthy neighborhood, 800 beds. There's nothing like it. And because it's San Francisco and there's such cultural diversity, literally all the wards are open, so there's no individual rooms, and the diseases are specialized. There was actually a ward there where there were patients who had dementia and spoke Mandarin. Right? I mean, there's the amount of specificity in terms of the different problems they had there was amazing. And because people came there and there was nowhere for them to go, oftentimes you had a large part of the population that would live out their lives there. So for decades they would stay. And so it became very much a social mission. The people that work there absolutely loved the patients, and that became, I think in many ways for the patients, the staff became their families. So I arrived right before the great financial crisis, and so I'd come there to start a palliative care program, and they eliminated my position. So instead they offered me a night job as an internist, which if you know internal medicine, that's not a great situation. But I ended up working there, and I would come in at dinner time and then work to the next morning. But the calls wouldn't start coming in until later, until the shift would change at 10 or 11 at night. And so I had these hours where it was just very quiet. And so this is a book called God's Hotel, if you've read it, by Victoria Sweet, one of the doctors that's worked there, that captures this. But this is, because it's San Francisco and the weather is temperate, the hospice was amazing, where it would be literally a hospice with open wards and then would open up into this internal garden in the hospital. So in the evening, I would go there and, being a hospice and palliative medicine person, just hang out. And almost every night it would be a patient or two that would be well enough to walk outside into the garden, myself and a volunteer from the Zen Hospice Project. And one of the things that came up is, as you can see, this is a photo of the garden. And in my prior life in Ohio, I'd worked at what would be the equivalent of Hopewell House here in town, so an inpatient hospice house. And this was nothing like that, right? So in other words, at a traditional hospice house, it's very sterile in many ways. It's beautiful, but obviously you don't have people writing on the walls or doing paintings or anything else. And so this struck me as some type of profundity, but I didn't know what it meant, right? Just walking this and talking. I would talk to the staff, and clearly all of this was done by the patients, right? So that was the first lesson. And the second lesson was, I was struck at, here it is, Laguna Honda Hospital, 800 patients, right? I mean, it was just massive, the amount of patients that had all of these problems. And so fast forward coming to Oregon, this is another picture, sorry, of a couple of mementos, right? People memorializing their lives. I was struck at, how big is this problem? In other words, how many people have this type of life, have these type of needs, are receiving healthcare like this? And so this was some of the work that it is finding out. It's not uncommon at all, right? So the California Healthcare Foundation, which does a lot of work in underserved populations, this is from their own analysis, 30% of all Californians, right? So I think there's 20 million people in California. You can do the math. And if you want to know what that means in terms of safety net in this definition, it means 300% above the poverty level, right? So it is a major population in the United States that has a complex set of needs that we'll talk about. And this is the definition of the safety net, right? So that population is served in the safety net. It's many populations, right? Many types of situations and life stories. But this is the care. The safety net are providers that organize and deliver a significant level of healthcare and other related services to uninsured, Medicaid, and other vulnerable populations, right? And I think the operative part here is the idea of net, right? It's the final net to catch somebody who, if the safety net's not there, they're not going to receive care. Right? So when I came up to Oregon and I was doing full-time hospice and palliative medicine, and CareOregon had set up a contract right before I arrived at the health system in town where I worked to provide palliative care for CareOregon members. And what struck me about this experience is that I was essentially living two different worlds. I was doing the regular work that I'd always done, which would be considered frail elderly populations, classic hospice and palliative medicine problems, figuring out goals of care, managing symptoms, end of life, and those things. And then it was like I was having an entirely different job where I would be taking care of CareOregon members who had all types of life complexity, right? Behavioral health problems, social determinant problems, housing, food risk, complex symptom issues, no caregiving, social isolation, the list goes on. And it just struck me how that path that I'd been on and seeing that one patient and then going to Laguna Honda in San Francisco, that this was all of a sudden in the middle of it, an immersion. And so eventually when CareOregon offered a position to develop this work more at a systems level, that's when I came here. And I would say the next learning step was around what does it mean for population health and those that are seriously ill and are in the safety net, right? So what are the things that we see when we take care of these patients? And I would say when I was in my job doing full-time clinical work, taking care of CareOregon folks, I didn't see these things clearly. I mean, I would have identified them if you would have provided a checkbox for me, but I was still lost in that world where complexity feels ambiguous. And that this is one of the steps in figuring out how do we address complex problems is being able to see the patterns and the archetypes of those issues. And so anyone that works in the safety net, these are things that you would experience to some degree in the patients you serve. Younger age, in our palliative care program, these are patients that are typically in their 50s and 60s, not 70s, 80s, and 90s. In Oregon, if you have serious persistent mental illness or you're chronically homeless, you die 20 years younger than someone who doesn't have those problems in Oregon. So it makes sense that a lot of the populations we serve would be younger, right? Obviously, the prevalence of mental health issues, just like I said, substance use disorder is prevalent, lack of social supports. That might be the single biggest one that I would say that strikes me as so stark in the contrast. In other words, I wouldn't be surprised if people are younger and they have mental illness issues more commonly, or they have more substance use disorder, but the degree of isolation is profound. Not just the lack of caregiving, but the lack of anyone in their life that would be considered a trusting relationship. Food insecurity, not just homelessness with housing, but also people that are at the risk of being homeless, right? Lower health literacy, which then informs things like goals of care, decision-making, understanding one's prognosis, decisions going forward. And then finally, people who are traumatized and the need for safety and hypervigilance that comes with that, and creating barriers so that we cannot serve them in the best way because that is a coping mechanism they've developed from their life experience. So those are the things that we see in taking care of them. But what is their side of this? What is their experience, right? So these are some of the system barriers. People don't have insurance, they have complicated eligibility requirements, services they experience as being disorganized. You go up to OHSU for one set of services, you're down here for another, you're across the bridge for another set of services, which leads into inaccessible service locations. People don't have documents or transportation, and then of course, they have complex medical and mental health problems. And then all of the things that really inform their life experience in dealing with the healthcare system, provider attitudes, discrimination, cultural incompetence, prior bad experiences, distrust of the system, language, illiteracy, disorganized lifestyle. And the one I'll tell you personally is that when I first came to CareOregon, for a while my office, which was a cubicle, was amongst the case managers. And I kept hearing a story, and I thought, I must be misunderstanding this, where the central work of the case management engagement was trying to find the person some type of identification. They had no driver's license, no birth certificate, they had nothing, right? And I couldn't figure this out. That just seemed so improbable to me. And looking back, I think, imagine experiencing serious illness like we're talking about, or even end of life, and not having the ability to even say who you are to receive services. I mean, it's a profound degree of depersonalization, right? So what underlies so many of these problems, right? And this is, I think, one of the main paradigms of population health, which is its traumatic life experience, right? Especially traumatic childhood experience. There's a wide and growing research base on how that affects someone's overall life arc, right? In other words, people experience life trauma. Poverty is in and of itself traumatic, and then all the associated things that come with poverty that are traumatic, and then they affect the growing brain, which affects emotional regulation, executive function, the adoption of coping lifestyles like smoking that have health consequences, right? And then lead to serious illness that end up in our program, right? And the triad of trauma, PTSD, anxiety, and depression, right? These are absolutely part of the primary care experience, I would say, in the safety net. And if you look at CareOregon claims data of the population problems, you can see this as patterns. But the second lesson is the idea that traumatic life experience, it's not that it's only in the safety net or only in certain populations, right? So here it is. This is an article in the New York Times, Nightmares After the ICU. People who have been in the ICU, 25% of them have PTSD in the following years, right? There's a growing body of evidence of the vicarious trauma that ICU nurses experience and their family members, right? So this is really not just a problem of people's life experiences in their regular life, it's that the healthcare system induces trauma as well. And even though I didn't put a slide in here, another important part of these is people that have had traumatic life experiences and then they get into the healthcare system where they're treated and it reoccurs. So in other words, you're reinducing the trauma, right, by the different interventions that we use for people. Finally, this is by the psychiatrist Mark Epstein, The Trauma of Everyday Life. Trauma is not just the result of major disasters. It does not happen only to some people. An undercurrent of trauma runs through ordinary life. And the way I would say this is, in my hospice world and taking care of really old patients. So let's say somebody's 100 and you're asking them about their lives. Always, there's a history of trauma, right? It's just the nature. If you live long enough, you will experience traumatic events. And so the point is, it's not that trauma by itself is the problem. Of course, we want to prevent trauma as much as we can. But it's also in the way that our system does not provide the right types of needs and interventions for people who have experienced it. Right? So just like I said, for those people who, if they've lived long enough to experience trauma, part of the assumption for most of those situations is that they've had relationships in their life, they've had a sense of security, so they were able to process that trauma in some type of way that has allowed their life to go on as a new normal. And when those factors aren't there, that's where someone is essentially held captive, right? A fragmented sense of self, a state of hypervigilance, those kind of qualities. So how does that apply to palliative care? So this is the traditional 3 pillars of palliative care. Palliative care being the discipline and the idea of serving those that have serious illness and need support, right? So there's symptom management, right? The sicker you are, the more likely you are to have symptoms. Especially as you become very sick, the number of symptoms you have goes up and the intensity goes up. The second is care coordination. Just like we talked about all those list of things, if you have a number of illnesses, a number of things going on, your care increasingly needs to be coordinated. And our system is the opposite of that, right? Fee-for-service healthcare is a fragmenter, not something that integrates naturally. And then finally, goals of care. Not just about the things that we talk about. In Oregon, this is the home of the POLST form, right? So in other words, do people want to be resuscitated and those dynamics? But really goals of care is, no one's life goal is whether they want to be resuscitated or not, right? Right? Their life goal is, I want to live long enough to go to my daughter's wedding, or I want, it's about a quality of life question. And so really, it's something more fundamental than what we want for them. It's what they want for their own lives in the context of experiencing a serious illness, right? But in populations for whom trauma is endemic, this is what we would say is a more realistic and more effective model, which is that all of these things are true, but really the foundation and the start of that work and the most important therapeutic intervention is a trusting relationship. And that essentially, when you touch patients in these ways, when you're involved in their lives, that is the primary goal, right? Is that none of these things happen well if this isn't there first, right? And you can say that a lot of ways, is that until someone has a relationship, it's hard for them to hold the uncertainty that comes with these other decisions, for example, goals of care, right? And so one way of saying that is that the spirit of doing this work, of doing palliative care in the safety net, is walking with patients. It's not doing for them, it's not doing something for them and walking away, it's allowing their life to unfold, but you walking with them to help them. So this was a study that was published a couple of years ago, and probably for every one of these slides, you could come up with I'm sure you could come up with an academic study to back it up, but I don't think that's so important. But this is particularly important. In fact, I've read thousands of articles over the years, and this is one of the top 5 ones I've ever read that I think is significant. And so I'll just explain a little bit of it. And this was done in San Francisco at the Palo Alto VA, and a very simple study in many ways. They took VA patients, so VA patients tend to be more complex, right? So they have a lot of the problems we've talked about here as a population. They have stage 3, stage 4 cancer. And this is all they did. They took lay health workers. So they took people that had a college education, trained them for a couple of weeks, so 80 hours of palliative care skills, focusing on helping people identify their goals of care, right? But what they did is, the intervention was a relationship, right? They visited them frequently, they called them, they walked with them for 6 months. So, and then in the control group, they had the same problems, they just didn't have that lay health worker show up. So they had all the other health care and all the other supports that you would normally get, right? So if I was reading this, if I would have been in the audience hearing what I just heard or just said, I would say, yeah, that would work, or that might do something good. And this is what we've believed in our program for years, right? So it's not something that this idea is new. It's the profundity of the effect. So the patients who had that lay health worker develop a therapeutic relationship with them and help them understand what their goals are in the context of stage 3 and stage 4 cancer. Here's the difference. They were 95% less likely to go to the hospital, the emergency department, in their last month of life. That is profound, right? And what does that mean if you don't go to the hospital or the emergency department in your last month of life? It means your symptoms are managed. It means you're acting out the goals you want, which is almost always, people want to die at home, right? Very few people say, I want to die in the hospital. I mean, there are people, but that's the exception, right? So that single relationship-based intervention had that profound of an effect. But here's the other irony. If you search this entire paper, not one time in the article is the word relationship used. So there is this disconnect, I think, in healthcare about, I'm not even sure, I would love to talk to the authors and say, why do you think this worked, right? And they might say, well, we got their goals of care written down, I don't know. But the person that introduced this article to me, a national palliative care leader, said, this is his exact point is this is a relationship-based model. So another lesson of this work is, I was looking over some of our data maybe 3 or 4 years ago, and I was noticing here are these patients that I had described as being younger. And by younger, I mean in palliative care terms, people that are in their 50s and 60s. But when you looked at their data from the CareOregon side, they had all of this frailty associated with them, right? They had the diseases and the conditions, the functional status impairments of people that were 10, 20, 30 years older. And so I was discussing this with a geriatrician at one of our clinics, one of our safety net clinics, and she said, oh, Will, geriatrics is a condition, not an age. And that was a great insight for me to think about that, is that really this work is not distinct from the work that is done in conventional palliative care that I've done historically. It's that work and then it builds out. So it is a form of geriatrics in a way. So as another idea, you can find 50 of these images online if you just Google palliative care or serious illness progression. And there's nothing, this is all common sense, right? You're diagnosed, you receive curative or life-prolonging therapy in the green. The assumption is if you're not cured, that at some point those therapies become less and less effective, right? And then in an ideal state, you're having more palliative care and comfort care along the way as those therapies become less of an issue and things like your symptom burden and your goals of care become a more prominent issue in your illness experience. And then at some point, there is no curative care. It's all focused on comfort, and you have a conversation and your provider says, how about hospice? And you join hospice, right? And then at some point you pass away and there's bereavement services, which is a requirement in the CMS Medicare hospice benefit for your surviving loved ones, right? That all makes sense. I mean, there's nothing nonsensical about that. But I can also tell you, 3 years ago when we looked at our data, it dawned on me how, even from these models, even though we were experiencing it a certain way, how much this didn't fit with our experience, right? So here's a pie chart of people that had come into our palliative care program at CareOregon. This was done at the end of 2016. And so you can see, these are people that come in with palliative care, and remember that sequence I just showed you. They come into palliative care, they get palliative care services, and then they go to hospice, right? But look here, just as many people die in palliative care as in hospice. They never go to hospice, half of the patients. Why do you think that is? That's not how the model's designed. It's not how the benefits are designed. That's not how people think about it schematically. Any suggestions? Any ideas? So the answer is a couple of things, I think. One of them is that patients who we take care of oftentimes have felt so disenfranchised from the healthcare system, they developed a survivor mentality, and hospice means disenfranchisement. So what it means is they're never going to go to hospice, right? Never. That's just not going to be part of their life. And so then it asks the question, if they're never going to go to hospice, but all of the benefits are in the hospice benefit. So the hospice, typically as a benefit structure, it might be 10 times as much funding and therefore care than in palliative care. Are we being fair? Is it a socially just system? Right? And so the second question is, so these people may not go there because they want aggressive care. It's both of those things. And then other patients, they say, maybe they just can't wrap their head around their situation. And so by the time they would have gone to hospice, they pass away in the program. Right? They want very aggressive care to the end or almost to the near end, right? So again, it's the same idea, is that is the system really designed for people who need it the most? Right? And so here's the problem, right, is that if people are never going to go to hospice and they don't have any loved ones in their life, they don't need bereavement support because there is no one that's left behind after they pass away. So that's a resource that's misaligned. And then, I mean, just like I said, they're not going to go to hospice, so that's a resource that's misaligned. So what does a socially just and equitable system look like to provide end-of-life services for people who are the most vulnerable, right? So, and the lesson is, it's parallel, not sequential, right? In that schematic, you're supposed to go to palliative care, hospice, and then your loved ones receive bereavement. So it's all in a row. But instead, we have to develop a system where somebody can have all those services and not be forced to make decisions along the way. So as I was trying to unpack this and understand these lessons, 3 years ago, I went up to the Ottawa Mission. And the Ottawa Mission is sort of like Central City Concern. It's a large housing and healthcare organization in Ottawa. It's been around since 1906 with its singular mission to serve the most vulnerable in the city. Do lots of work with those that are homeless, and I think probably it's fair to say that they do the best care, end-of-life care for the homeless in the world. They've done it for 25 years, they've built a unit, so I was going up there to see in person what it would be like. And actually one of the medical directors from Central City Concern flew up there with me for the visit. And so I'm up there talking to them, and I can't remember why it came up, but I brought up this experience I had at Laguna Honda and looking out, and just a curiosity, like, you know, it was so different. And they were, I think because they were talking about how they felt the care that they gave for those who were homeless and end of life was just so different than the rest. And so that prompted me to think about this image in the garden at Laguna Honda. And the director there, the executive director, started the program. She's been there for 20 plus years. And she just smiled and said, oh yes, we have the same issue. And so this is the Ottawa Mission. You can see that's an old building. We have the same thing. And so we have created a plaque on the wall in memory of our friends who were loved and cared for at the Mission Hospice. We miss you, right? And so the point of all of that at Laguna Honda, with that garden as the same thing that is shown here with the plaque, is patients who don't have anybody, the idea that they are building legacy and memorializing their lives happens when they're alive, right? Because there isn't someone that's going to continue their memory, and like that idea of bereavement. And so this is the natural need, right? The people are carving their names on the tree in the Laguna Honda garden. This is the plaque that they've created, right? So again, it gets to, are we providing the kind of care that meets the deepest human needs for the people who are most vulnerable, right? So does anyone know what this image is from?
France.
Yeah, so it's the Chauvet Cave. Yeah, the Cave of Forgotten Dreams, Werner Herzog. If you haven't seen it, it's an amazing documentary. It's one of the oldest cave painting sites in the world, and it's a great story. These three climbers feel an air draft coming up, and they cycle all the way down, and so then they walk, into this cave, and it's like, like out of a movie, that there's just all these amazing drawings in there that have been there for 30,000 years. And there's a point in the documentary where he comments, somebody had to walk into the cave with a torch because it's like a half mile in the dark. And it's like, 30,000 years ago. And had to take dry red pigment and put it in their mouth, put their hand up against the wall, and then blow the paint there to create that image. And so, and the reflection is, of course, it's this deepest human need to know, I was here. Right? Just like the memorialization in the Laguna Honda Garden and up at the Ottawa Mission, this is just a foundational part of being alive. But these are patients that otherwise don't have that opportunity, right? They don't have those relationships in their life to have a sense of continuity. So this is a South African phrase, a person is a person because of other people, same idea, right? So why does this matter now? Why is this so important? We've talked about my personal experience, the experiences at Laguna Honda, the fact that the safety net is not just a small percentage of the population, but it's a big part of healthcare, right? 30% of all Californians. So like I said, 30% of Americans are uninsured or on Medicaid, right, across the United States. There's a lack of structures in place to provide serious illness care in Medicaid. And why is that? Medicaid historically has been moms and kids, right? It hasn't been a system that's been designed to care for really sick people. Right? America's essential hospitals operate, so essential hospitals is another way of saying safety net hospitals, operate on a much lower margin than hospitals who are not safety net hospitals. The updated data here is maybe it's 4% and maybe 8% for non-safety net hospitals. So the point is, hospitals, when really sick people are admitted to the hospital, even though they get paid more money by health plans, it's not enough to cover the expenses oftentimes. So if you have a demographic wave of people coming in who are very sick, that could be a systemic risk for those hospitals, right? Especially if there aren't support services like we're talking about in place. And there's very little data to know how to care for these populations, how to provide palliative care for folks who are highly vulnerable and highly sick. And I can tell you, when I came to CareOregon 7 years ago and called around the country, I would hear somebody in UCSF was doing this work, somebody in North Carolina. And so I would call everybody up, and the answer always was some version of, yeah, we don't really know, but if you figure it out, call us back. And then a couple years circled around where, since I was always calling around, it got convoluted. And then the rumor became that I knew how to do it. And so a couple years later, people would be calling me saying, I heard that you know how to do this work. But in reality, it all been started with me reaching out and asking how to do it. But the point is, there's a great need for this. I gave a webinar last year for a national palliative care organization, and they had one of the highest signups that they've had, right? Over 300 participants in the country signed up. Some colleagues were just at one of the big conferences, and it was standing room only for their section. So this is, I think, a huge need. We're seeing this. It's not just my experience or our experience here. So older minority Americans will increase 160% compared to 59% for non-Hispanic whites in the coming years. In some urban low-income neighborhoods, the percentage of decedents receiving hospice care was less than 5%. So in our community, it's about 50%, so it's about 10 times less, right? And then, as we've seen, the opioid epidemic, the flip side of that is, who doesn't get access to opioids when they need it with serious illness, right? So it's a double negative. There are people with chronic pain who it is not well serving them to receive opioids, but then the population strategies then can restrict opioids to populations who need it most, right? So this is a quote, and I have stolen this from one of my colleagues at Housecall Providers, Kelly Ambrose, from the famous Harvard public health physician Paul Farmer. For me, an area of moral clarity is you're in front of someone who's suffering and you have the tools at your disposal to alleviate that suffering or even eradicate it, and you act. And so my first point today is, I personally, in the last 10 years, have gone from a place of really being uncertain of how much you can serve these populations at end of life. I mean, so you might say it was more of a moral mission and something where I was personally affected by my inefficacy in caring for them in my full-time clinical world, to now, 10 years later, I have no doubt. Right? You can provide this care, but it requires a lot of different ways of thinking about it, building systems and so forth. And so that, in a way, that's Paul Farmer's story, right? What he became famous for was the ability of teaching communities to manage TB in Haiti, right? Which was thought to be that they couldn't do it themselves and so forth. So that's a consistent narrative. So I want to tell you, this is a story of Cynthia. She's a patient who was in our program, our palliative care program, also called ACE, Advanced Illness Care at Housecall Providers. Cynthia grew up in Indiana, came from a big family, and loved horses, migrated out to California, and spent many years there before coming up to Oregon. And during her time in Oregon, she had insurance through her partner, so she was approaching, I guess it would be, she was approaching age 50, and she was scheduled to get a screening colonoscopy just as a part of a regular, preventative health care. And a few weeks before she was scheduled to have the test, so it was already scheduled, she was to go in, she lost her health insurance. And I think this was part of a bigger disruption in her life. So she had many things going on, that were related to not just losing her insurance. And as it would be easy to happen, she didn't get that screening test. she had bigger issues to deal with in her life at the time. Fast forward however many years, and she develops metastatic colon cancer and doesn't have a house, doesn't have food, needs food, has everything happening at the same time. So she ends up in our program, and sequentially those things happen, right? She receives expedited housing, food resources, and then helping really support her in dealing with her very serious illness. So her nurse, Monica, and I went out and saw her at her supportive housing and spent time with her. And I think maybe we spent an hour and a half with her, and I think I only asked her 3 questions. And she was incredibly articulate about her entire life and her illness experience. But part of this was how grateful she felt for the care that she received. And to my amazement, a big part of what she was trying to say is she had this sense that there were many people that were in her situation. And by her situation, I mean had a series of bad luck events and then had all of these problems beyond her healthcare needs, but couldn't articulate it in the way that she could, right? And so she was an artist, and so part of her art is up at the Heathman Hotel here downtown. And I don't know if there's a way we can play the audio or not. Ian, is there a way you can click that? We can.
Is there anything that you would want the physicians and nurses and nurse practitioners and anyone else that's taking care of you, is there anything you'd want them to know and what you've experienced or what you see now?
Just how important it is to us. And I'm sure some of us as patients aren't able to show our appreciation or to verbalize it. And so I'll speak for them. It really means a lot to us.
So this is it, if you can't hear it, because she's kind of soft. Both of us are soft there. What she wants you to know is just how important it is to us. I am sure some of us as patients are not able to show our appreciation, to verbalize it. So I'll say it for them. Don't stop, right? And so that really segues to the second part of the message, which is how much burnout and overwhelmed we are as healthcare providers, right? And how where our status is as healthcare providers does not align with these patients' needs, right? So this was last year's National Physician Burnout and Depression Survey. And I always say this is that there's better data on physicians and burnout, but having looked at the literature, it's across the board, right? Social workers, nurses, et cetera. So I'll just ask as a question, what do you think is the burnout rate for internists and family docs?
40%.
Okay. Okay. So 40 and 50 high. Anyone want to price us right it like any higher? So, okay. So those are good guesses. So overall, for all physicians, 42%. Internal medicine, 46%, family medicine, 47%, right? And the best way that I think about this is it's the percentage of physicians that say, would I do this career again if I had a choice? And that percentage is high that they would not, and they wouldn't recommend it to someone else, right? And there's both system factors and individual factors for that, right? The system factors are things like EHR and these things where people feel like they're staring at screens all day. And there's the individual factors where we might feel the moral distress because we're not able to help the patients in the ways that we want because we have short visit times, there's big quality metric agendas for visits, et cetera. And of course, in the populations we're talking about, all of those factors are intensely negative, right? These are patients that need time and space to have these discussions in these relationships. So how about burnout rate for palliative care physicians, my folks? No guesses? So 62% plus. And the biggest problem with that is there are very few palliative care physicians in the United States. There's a huge gap. So the same author, Arif Kamal at Duke, who did this study, also did a second study saying is that for every board-certified palliative care physician in the United States, there's a need of 4 or 5. So who's going to care for these folks, right? It's not going to be the palliative care docs. For every board-certified, for every palliative care physician in the United States, there is a need up to 4 or 5, right? So, and you remember 10,000 people join Medicare per week. I think the gap gets worse as time goes on, right? And I can say that personally. When I went into palliative medicine 15 years ago, I mean, I remember people's reaction was more like, what are you doing? Or what is that? And now there's just job listings everywhere for these folks. So a lot has changed in the last 15 years. So why is that so relevant? You have almost half of your primary care providers, you have large populations of your nurses and social workers who feel burned out. What are the qualities of burnout, right? Depersonalization, lack of efficacy. Well, those are the worst traits to have in terms of helping somebody who's dying or has serious illness, right? I mean, that's just not a good combination for either side. And so what happens when you feel those ways and the person has great needs? You feel more moral distress, which accentuates burnout, right? And so this is the part that we talk about, which is instead of going from triple aim, we talk about improved population health, reduced cost, and better patient experience. The fourth pillar, the quadruple aim instead of triple aim, is healthy and resilient providers, right? So there is no silver bullet for burnout, and that's certainly not the conclusion of my talk. But it is talking about some of the things we've done to think about how do you align care for providers that's better and for these populations that I've described today. So this is by Tony Bach up at the University of Washington, palliative care oncologist, does a lot of work in burnout. And talking about, like I said, there's individual skills and workplace factors. So this is one of his core pieces of advice. You prototype and iterate. You don't sink all of your resources thinking there's one solution to this problem, because it is truly a complex problem, right? You can't all of a sudden get rid of EHRs, right? Which is a huge problem, et cetera. So you build bridges. You have a multi-stakeholder approach, which means, I think in many ways what that means to me is, especially in taking care of seriously ill populations, is that you think of it as a community effort, multidisciplinary, across different stakeholder, whether it's specialists or community agencies. How do you think about building those relationships, right? When I first came to CareOregon, what really stood out to me was how deep its relationships were with the network and how essential that was, and how much I wasn't even aware of all these resources when I was out practicing. So this is one story and really leads to Housecall Providers, which is where I work and where we serve this population. This is Dr. Benneth Husted, who was the founder of Housecall Providers 25-ish years ago, and very mission-driven person, and realized that there was a population that was in need, homebound, and started the practice literally at her kitchen table. And I think I knew Benneth before she retired, and if I remember it, she said this right, is that for the first year she earned no salary. It was just purely a mission-driven effort. Now Housecall Providers is 1,700 plus patients, 20 plus primary care providers, hospice, palliative care. You can see here. These are some 2015 statistics, but it's just amazing what one person with the right orientation in meeting the need, if dedicated to that purpose, can accomplish, right? Because it draws other people in that want to do good work. And so several years ago, I've seen patients for Housecall Providers even when I was at CareOregon, but 2.5 years ago, CareOregon and Housecall Providers merged, and Housecall Providers became part of the CareOregon family, you would say, and specifically, they became part of this ongoing 25-year mission of CareOregon to better serve patients who are vulnerable and need support. Right? So this is a model of bringing care to patients who have serious illness, whether it's primary care, palliative care, or hospice. Right? So this is our palliative care program, which started about 10 years ago, where I worked, like I said, at CareOregon, and now has been built out at Housecall Providers. And so this is a care model designed to address the needs that I've been talking about. Patients that have had traumatic life experiences, who are isolated, have ongoing behavioral health and social determinant issues, and are very medically sick, right? And so it's a model that, what we would call a WRAP model, and that is, it focuses on nurses and social workers, some chaplaincy, pharmacy, and community health workers or lay health workers to really wrap around these patients and help connect them to their health care and provide those therapeutic relationships, right? So in your slides are how to think about patients that might be appropriate for the model, and then how to refer them. And one thing I would tell you here is, patients, just because they are very sick, does not mean they automatically end up in the program, which sounds obvious, but it really is. There are 3 distinct steps of identifying patients that are appropriate. They're very medically sick, they have ongoing needs. then referring them, which is essentially connecting them, and then actually enrolling them and paneling them in the practice. All three of those steps are skills, right? And so the reason I say that is because in patients, just like I described, who often feel very disenfranchised, for whom hypervigilance is part of it, distrust, et cetera, is that walking patients through this process may make the difference or not whether they actually get into the model and get the care that they need, right? This isn't like giving somebody a phone number and saying, hey, give them a call, they'll help you out. So finally, as that final idea of how do we think about the long game of serving this population, it's not just about building new systems, building new relationships. It's also about designing care that makes sense for these populations. Does anyone know what this building is? Or does everyone know what this building is? Okay, so this is the Blackburn Center. So it opened in July of this year, and it is 6 floors. It was funded by all the city health systems, plus CareOregon, plus other funding sources. And the bottom 2 floors are a federally qualified health center. It's on the east side, run by Central City. And the top floors are supportive housing, but on the 3rd floor are beds where you could have patients who are seriously ill, who are homeless, right? Because there is no other model to care for these folks like that. People who are homeless don't fit well in the hospital, they don't fit well in nursing homes. Obviously, the last thing we want is somebody to die on the street, right? And so this speaks to this idea that for serving certain populations who are high need, is that redesigning the system and building out new structures and new models is a critical part of the process. Just like Benneth Husted 25 years ago realized building out a practice that brings healthcare into the home is what patients need who are homebound or who can't get into the clinic and have other types of needs like that. So again, 25-year history of CareOregon, 25-year history of Housecall Providers, and I think the Blackburn Center will be another part of this narrative of what a journey looks like. If you want to go fast, go alone. If you want to go far, go together. These are community-wide efforts, and I think that's one of the answers that the Ottawa mission gave me, was that they don't think of serving this population as their mission. They think of it as the City of Ottawa's mission, right? They partner with the criminal justice system, the hospitals, EMS. They have tremendous community support. That is the way to think about serving the most vulnerable populations, that it's a way that humanizes all of us. So this is Bill Gates in the same talk, talking about the why of this work. But humanity's greatest advances are not in its discoveries, but in how those discoveries are applied to reduce inequity. Whether through democracy, strong public education, quality healthcare, or broad economic opportunity, reducing inequity is the highest human achievement, and that is absolutely what this work is about. Questions? Thank you very much for listening.
We are doing great on time, folks. So if a couple people do have questions before we go to break, this is a good time. If you've got something that's burning you'd like to ask Dr. Kennedy.
As far as referring patients for the AIC program, what's the time, like when you place a referral, what's the timeline for them getting into that program?
I'm going to go to Kelly on that. I mean, I want to give the best answer.
When we receive a referral for the Advanced Illness Care Program, our goal is to be in touch with the patient within 2 days. And if we're not able to reach the patient, we're going to reach back to the referral source and say, hey, are we missing something? Oftentimes, we'll come meet them in the clinic the first time. We'll know when an appointment is, and we'll work with you to get in there to see them. But generally, within a few days of getting the referral, we make contact. So.
Other questions, folks?
Oh, right here.
Sorry.
So I was looking at the picture in terms of the representation of staff that comprise Housecall Providers. And my question is coming from the African American community, not that I speak for the entire community, but because I'm a member of, and my mother actually utilized Housecall Providers. So my question is around, what does your outreach look like in terms of staffing so that the folks that are going into people's homes are a reflection of the clients that you serve?
I think that's a great question, and I think that's something we're working on. I mean, it's absolutely been an active discussion, and I think it's a work in progress, you know, in terms of equity, diversity, inclusion, within our practice, and then how that is then also allows us to engage populations better. I mean, I absolutely. So it's an ongoing process. And I think that probably the other piece of that is a truth, I think, is that until we do that, or the more that we do that, the more we're able to engage those populations, right? I mean, there's absolutely that relationship there. Yeah. So, yep.
Okay. I'm not seeing a forest of other hands coming up, so I think this is a great time for us to go ahead and take a quick break. We'll take like 10 minutes, folks, and we'll come back and we'll continue on. Again, please give a huge thank you to Will. Thank you, everyone.